So, good afternoon. This is Vaid. Um, Today, I'm going to explain you one of the topics in immunology, and today's topic, which we need to learn through this video session, is Digeorge syndrome. So, so one of the immune cells, when we talk about the immune cells. So the immune cells are divided into T cells and B cells. So among the T cells and B cells, this is the deficiency of T cell disorders, where Digeorge syndromes fits in. So how this T cell deficiency happens and T cells deficiency happens and how it is going to present physically, how it is having all the physical symptoms is what we are going to discuss today. So before we understand Digeorge syndrome, there is one another name you need to know, and it is called cardiofacial syndrome. So it's very important to understand what is cardiofacial syndrome. So the velo itself is the palate. Velo is the palate. Pharyngeal is pharynx. So whenever velo and pharyngeal goes hand in hand, and cardiofacial syndrome. So velo is the palate. Cardiofacial is cardiac. Facial means facial anomalies. And syndrome is a group of disorders. So here, I have already taken a famous picture of Digeorge syndrome where I'm explaining you this. So velo is palate, cardio is heart, and facial is the face. And that pretty much makes sense, and that is the reason they are named syndrome. Now, so though this baby is gonna have all these manifestations of cardiac, face, and palate disorders, there is one more important thing which you should understand with Digeorge syndrome, and we are gonna discuss how it's gonna have the T cell deficiency, and that is predominantly, if you remember, we know T cells get matured in thymus, and thymus is normally is where the T cells get matured, and B cells get matured in bone marrow. That's the reason they are called B cells. B means bone marrow, bone marrow. Whereas T cells are called T cells because the T refers to thymus. So, but both the cells eventually come from bone itself, the bone marrow itself. So B cells also come from bone marrow, T cells also come from bone marrow, but it is the thymus which the maturation takes place for T cells, and then they become immunocompetent. And B cells, they mature here itself, they don't need to travel elsewhere, and then they become mature or competent, and that's where they're ready to take in the role of fighting the infections. So this is what you should understand. So when I told you there is T cell disorder, that pretty much means that this thymus is defective. And remember, this thymus comes from one of the pharyngeal pouches. So that pharyngeal pouches, if you remember, it I'm gonna take you back to the embryology. So this is an embryo. This is an embryo. So this embryo, if you can see, embryo's neck has a group of gills, and that gills have structures where there are six arches, five pouches, and clefts. And on the lateral side, it something looks like this, and below that is heart. If understand this, this is very important to learn because um, this is the area where thymus develops from one of the pouches. We'll understand when and how and where it is. So you can see the lateral section of the embryo looks something like this. And when you look from the front, it looks something like this. And each of the segment is divided into a bunch of block, and this is called arch. And between the two arches, from the inside, it is pouch. And this is the pouch which we were talking about. And from the front, when you see from outside, it is cleft. So here, when you see the things which we are seeing from out, they are clefts right here. So, so this happens to be the first arch, second, third, fourth, and subsequently we have fifth, which gets rudimentary, and then it's sixth. So if you can see, the first arch and second arch will give the first pouch. Second and third will give the second, third, and fourth. That is how it is numbered. Now each of the pouch is gonna be modified with time, and then it looks something like this. So you can see here, I'm gonna show you in this order. You should understand this in this order. Go like this. So remember, we just discussed, if you see from inside, it looks something like this: arches, and outside it is called grooves, or it is cleft. So, and inside it is pouch. If you can see, this is the pouch, this is the pouch, this is the pouch. Now you can't differentiate properly in the initial stages. We are gonna see this in a mature embryo, where you can see the differentiation all has already started. If you can remember, we have 3 trimesters in pregnancy. So, and totally each trimester has 3 months. That's why it's called trimester. And 3 trimester and organogenesis. Organogenesis happens in the second trimester. And that's the reason you can understand all this organelles happens to be in this stage, and pretty much in between first and second trimester here. Now I have already numbered here. So the first pouch here, the first pouch gives the pharyngotympanic tube and tympanic cavity. The second pouch is the palatine tonsil, and the third one, you can see the arrow, how it's going to descend downwards to give you thymus. So that is the third pouch, and also it's gonna give you, if you can see, inferior parathyroid gland and again it is third pouch derivative. Now coming back to fourth pouch, the fourth pouch gives to superior parathyroid gland. Remember, parathyroid gland releases some hormone. It is called PTH. And PTH is what? What does it do? It increases the calcium level, and it flushes out phosphorus in the urine. That's the reason it is called phosphorus trashing hormone. And it increases the calcium and it decreases the phosphorus. So this is what we should understand. So let's suppose we don't have both the parathyroid glands, then we don't have PTH. And if we don't have PTH, we don't have calcium. And where do we want calcium? We want calcium for muscle contraction. We need calcium mainly for muscle contraction, and there are other clotting factors as well. Remember, clotting factor 4 itself was calcium. We need for many other places as well, many coenzymes. So all these important domains doesn't get calcium because the parathyroid gland is not formed due to this third and fourth pouch defect in Digeorge syndrome. So whenever that is there, what do you see? You have no contraction or tone in your muscles, because even to maintain tone you need calcium. So because you don't have calcium, you don't have tone, and that baby will have atony. And because there is no calcium, the tonicity is gone. That's the reason. That's the reason the baby is having atonia. Now let's understand the thymus. Even because the third pouch is absent, it also contributes to the thymus, and we don't have thymus now. Now T cells, remember, is born from the bone marrow. They are born from the bone marrow, and they mature in the thymus. In the thymus. And when the maturation doesn't happen, the T cells are not immunocompetent anymore. And that's the reason this baby is gonna have lots of infections. So it is as similar as having something like HIV. In HIV, the viral particles uh, tries to take dominance over CD4 cells. So they are T cells, T CD4 cells. And the same way, when there is no immunity, when there is decreased cell count in the T CD4 cells, so it has similar effect with Digeorge syndrome as well. So that's the embryological basis for that. And you can see that hypotonia is due to calcium deficiency. So because calcium is also needed for the neuronal activity during the early stages, absence of calcium also causes CNS disability, neuronal disability, which is due to calcium again. Now you can see the parathyroid glands are absent, you can see, and that is due to absence of both third and fourth pouches. And that's the reason we have calcium deficiency in both these symptoms. And you can see here the thymus is also absent, and this is the very reason. This is because of the third pouch being absent, and that results in a characteristic X-ray finding, which is absence of Sale sign. So normally the Sale sign is presented as like this. Because it is absent here, it denotes that thymus is hypoplastic. Maybe it is very shrunken, maybe it is somewhere here between, in the midline, it is not big enough. So that's the reason we are unable to see that. And you can also see from the lateral side of the X-ray, we could not even demarcate the thymus. So this is very important finding in Digeorge syndrome. There is this absence of Sale sign in other syndrome as well. We have severe combined immunodeficiency. So combined is both T and B cell again. So you can also see that there. It's not just in Digeorge syndrome. So this is that characteristic Sale sign. The other important stuff where the Digeorge syndrome is also called, as we discussed earlier, was cardiofacial syndrome. So because of this genetic defect, which is 22q, the defect of 22q results in this genetic heart conditions. Predominantly it is the tetralogy of Fallot, which commonly presents in Digeorge syndrome, comes up here. And remember, tetralogy of Fallot happens in four steps. It has four important things. So one, the spiral artery has the spiral septum. The truncus arteriosus has the spiral septum, which divides into aorta and the pulmonary trunk. This spiral septum here, that divides unequally, and that results in having asymmetrical division. So pulmonary trunk or artery is more here than compared to aorta. So that is called overriding of aorta. And if you can understand, whenever in the heart we have pulmonary artery comes from here and aorta comes from here, and if the pulmonary artery, if the okay, so this is the opposite side which I have told. So it is the artery, the spiral septum takes major portion on the pulmonary trunk, and that causes stenosis of the pulmonary artery. So stenosis of the pulmonary artery here causes the right ventricular hypertrophy, because it needs to work lots of more and more, so that results in right ventricular hypertrophy. And if you can remember, the ventral septum is made up of two components. So one component is membranous part. And the other component is the muscular part. And along with the truncus arteriosus, the membranous part also develops. And when this anomaly is there, you would be able to see that you don't have this ventral septum, this membranous part. So now you can understand it is this defect where you can see the spiral septum taking lots of space of the aorta to push near the pulmonary trunk, results in pulmonary stenosis. And why did this happen? This happened because of overriding of aorta overriding. And what results in this? This results in right ventricular hypertrophy. So this is the mechanism, and because there is ventral septal defect, the blood will transfer here. So this is what commonly seen in Digeorge syndrome, and very commonly if you can see an ASD here, that is called pentology, because it has 5 components. So apart from that, you should also understand that the people of Digeorge syndrome who comes to the emergency room also shows up with different kinds of faces, and it is hooded eyelids, ptosis, and hypoplasia of the auricles. You can see the pictures here, hypoplasia of the auricles and the ptosis. And because these people have the defect in the cleft palate, it is called cardiofacial. Now it makes sense, because it has cleft palate and tetralogy of Fallot in the heart, and facial features, which includes eyelid deformities where it has ptosis and it has hooded eyelids, and also hypoplasia of the auricle. This facial feature characteristics, this is called velocardiofacial syndrome. One of the important things we should also always remember is that we should never give these patients live vaccines because they don't have T cells to be immunized. That results in infections. And on lab investigations, you would find less calcium and you would find decreased PTH. Makes sense because of no absence of parathyroid glands. And apart from that, the genetic analysis will show 22q defect. I hope you understood this. If you have any doubts, please feel free to reach out. Thank you.